everyone. Good morning. It is the top of the hour. Welcome to the Superior Health Quality Alliance Coronavirus Disease 2019 All Care Setting Call. We appreciate you joining us today. My name is Nikki Kemmer. I'm the facilitator for today's call. I'm a Quality Improvement Advisor with Medistar, a member of Superior Health Quality Alliance. Superior Health is made up of 8 entities: Medistar here in Wisconsin, Stratus Health in Minnesota, Empro in Michigan, the Hospital Associations of Minnesota, Wisconsin, Michigan, and Illinois, and along with Midwest Kidney Alliance. This call was developed to assist healthcare teams across the care continuum to share successes, barriers, and best practices related to the care of COVID-19 patients. This is your call, and we encourage you to participate by asking questions, sharing ideas, and best practices. Today we have a featured presenter backed by popular demand, Dr. Bobby Redwood. Dr. Redwood will share with us some strategies he and his ER team have implemented in counseling support for peers and behavioral health interventions for patients.
All right, thank you so much. Well, I'll just get started. I know, last time I felt like I was talking a lot and we ran over time, and that's great. This time I think the scope is appropriate, that we can have a lot more room for questions and kind of go on any detours if we want. Again, I'm presenting from Western Massachusetts, and I know that I'm very aware that the epidemic is hitting the Midwest right now. And there's certainly hot spots in South Dakota and Iowa, and so my heart goes out to everyone. I know that the long-term care facilities in Minnesota are particularly hard hit, and so just we feel your pain. We are with you, and this is definitely a time of national unity and interstate collaboration, and so I'm glad we're having this conversation. To just give you an update on the Massachusetts situation, again, we're in the western portion of the state. You can think of it like Illinois, how there's population dense Boston and population dense Chicago, and then southern Illinois or western Massachusetts is certainly quite a lot of people here still, but doesn't have that dense urban center in the same way. And so we're not feeling the hurt in the same way as Boston, but the statewide numbers are quite devastating, I would say. Last week when we talked, we were at 60,265 confirmed cases and 3,405 deaths. We are now at 79,332 cases and 5,141 deaths. And our local veterans home, Veterans Long-Term Care Facility, Soldiers Home, has the unfortunate distinction of #1 in the nation for deaths in a long-term care facility. They're in the high 70s. And so, yeah, it's just very real. It's ongoing. Just this week, we had 2 staff in the ED test positive, and a subsequent tracing and surveillance testing operation to make sure that we weren't going to have our own outbreak in the ED. Luckily, we just tested 50 staffs and had no more positive after that. So, but yeah, it's I would say even though you see these curves starting to flatten, it really tells a misleading picture in some ways, because a flattening curve doesn't mean that there is not ongoing death and suffering, and we're having micro outbreaks. So you might see a statewide curve start to bend, whereas individual communities are having, very much soaring in terms of cases and fatality rates. And so it's just important to be in touch with your local data, your local public health resources, and try to predict what's going to happen 7 and 14 days down the road as much as possible. I think that's the position a lot of us are in right now. That was just an update sort of on where we were. Last time we had talked about care innovations in the emergency department and at the hospital level that we've implemented for COVID. And the part that we didn't get to was sort of the psychosocial well-being of the staff and the patients. And I wanted to address that today. And we'll end with the experience of a behavioral health patient, because this is a particularly vulnerable population, a population that we see frequently in the emergency department. And I would say that we've adjusted the way we deliver care pretty significantly for the behavioral health population, at least here in Western Massachusetts. So I'll start with the director level experience of what is my role with staff, for staff wellness as a director. And I would say the #1 role is keeping the calm. The departments that I have seen struggle the most, I have, in my personal opinion, have have sometimes been because their director is so stressed out. And it's very easy to get stressed with all this. Our workload has increased dramatically. The number of care innovations that we're trying to deliver in a rapid fashion is just, a rule of thumb for anyone in quality is you never roll out a new process at Friday at 4 p.m., right? And I feel like we're rolling out new processes overnight. And it's because there's a need for it. It's not inappropriate, but it's just things are changing very rapidly, especially with testing criteria. And so that's part of my role, even if I don't feel calm on the inside, is to project calm. We're all going to get through this together. We're all in this together. Thank people for coming to work today. Keep a smile on your face. I definitely use humor a lot, and just not like gallows humor necessarily, but oh, my family hates me. How about yours? Oh, the kids are underfoot. That kind of thing. Just maybe making light a little bit of the quarantine situation and the chaos that has become all of our lives recently. And just try to give people an opportunity to vent if they need to. If you notice somebody, interpersonal issues will inevitably spike during this time. And so general calls for humanity in our weekly emails to the staff, taking people aside if they've been snippy and just saying, how can I help support you? What's going on? Definitely not taking a judgmental tone about it, but more of a compassionate tone and say, I feel you, I have empathy. I noticed this happened. What can we do to support you? Approaches like that. A lot of people are thinking about keeping their family safe too. It's very real. As a healthcare worker, you're going home to your family every day. We do not have a situation in the United States where there are COVID hotels, and when you test positive, you can quarantine yourself from your family. We go home. We go home to potentially infect our spouses and our children. And, I think a lot of the world is like that. That's not necessarily wrong, but it's certainly anxiety provoking. And so from the emergency department standpoint, it takes a lot longer to get to work and to get home again. So I'll just start, my day when I get to work, I've got to log into my computer from home. We open our app. We say that we don't have any symptoms. We screen for clearance. I take a picture of the screen on my phone so I can show it at the door. I have to go through a special entrance that's far from the parking lot. I have to wait in line as we all sort of show our pass that we're not exhibiting infectious symptoms this day. And then I get my mask for the day. So, just the process of getting to work takes about 10 more minutes. Ironically, there's less traffic. We do have a bridge bottleneck, so sometimes it's a wash, but getting into the building certainly takes more time. And then when you get to your workstation, it's Virex everywhere. We ran out of the wipes, the reusable wipes long ago. And so we have these big industrial spray bottles of Virex and big stacks of kind of heavy duty paper towels. And we're wiping everything down. My dictation microphone, my chair, the keyboard, all the things I'm using on a regular basis. My iPhone's in a plastic bag. iPhones have been found to be a significant transmitter of the disease. And so it's just sort of a world wrapped in plastic being cleaned constantly. We're all moving to let the cleaning staff through multiple times a day. We're flashing the room with UV lights, sort of our physician documentation hub. And so being at work just takes a lot more time. I am wearing separate clothes to the hospital. So I sort of have my clean clothes when I go to the hospital with my clean shoes. And clean is probably in quotation marks there. I sit in my work car, which I'm not letting the rest of my family use. It's my car only during this time. And then I go directly to the locker room, put all my clothes in a bag, change into my work clothes, and then go out to the floor. And then when I finish my shift, I shower on shift, change back into those work clothes and drive home. And then as soon as I go home, I put all the clothes directly into the washing machine. I don't take the shoes into the house. I leave them in the garage and walk barefoot about 20 feet on my stone driveway into the house. And then I basically decon. So I wash my clothes and go directly upstairs and shower. And that's been our strategy and our suggestion for staff for keeping your family safe. But you kind of have to say it. You kind of have to lay out a process because people are really worried about it. They're getting an earful at home. Are you going to get us sick? What's going on? You've probably seen articles about healthcare workers being stigmatized for possibly being infectious vectors. And I think we have to do our best to give people guidance on how to minimize all of these stresses. That being said, it is, at least in our community, it is protective to be a healthcare worker right now. So our infection rates are lower than the general community. I think that's a secret, not broadcast in the media. The media really portrays us as being at higher risk. And at least in our experience, the reason I think we're at lower risk is because we know who's in the room. We know who's infected largely. We know who's symptomatic. We mask up the patient. We mask up ourselves. We scrub ourselves, up and down. We've cohorted the patient into our respiratory ED and our normal ED. And we sort of at least have a lay of the land that a worker at a supermarket might not necessarily have when they're swiping 200 credit cards a day or whatever. And so at least in our community, the infection rate for healthcare workers has been lower than that for the general community, which is, I mean, that's an important point of keeping people calm, is really not just keeping people safe, but messaging that we're keeping you safe and showing the results. Obviously, we're in a time of reusing PPE. We're in a time of severe shortage. We're now doing this hydrogen peroxide cleaning process for our N95 masks. So I come to work and get an old mask that I wore a week ago, and it's just kind of weird. And you want to try to demonstrate to your staff that it's effective, if that is an option, if you have that data. Finally, I'm just thanking everyone for being here. You know, from the custodial staff to the cafeteria workers to the person who hands me the mask in the morning. Just thank everyone. You know, there's an attitude of gratitude during this time goes a very long way. And we're all putting ourselves at risk being on the front line. And that process of saying thank you, I think, is very uplifting, or can kind of get us through the day. And we just say it to each other. We back and forth. I thank the nurses thank me. And it's sort of this mantra that we acknowledge that it's really important that we're here, that we all have stress, but that we're doing good work, and it's very purposeful and hopefully time limited. Hopefully there's going to be an end to all this where we can get back to normal. And then probably one of the most stressful things for me as a director has been what people really want to know is that they're not going to lose their job. This is a very interesting time. It's a time of extreme spending. So we are hiring more staff. We are opening new care areas. We're buying all this PPE. We're buying ventilators, buying. And then we know, just by definition, that in the next month or two, or already starting, we're going to be in an area of debt, of significant debt. Our states will be in debt. Our health systems will be in debt. Grants will dry up. Patients will dry up. And so the question is, and volumes are down. Again, the irony of this epidemic is people are actually fear hospital to some extent. And so ED volumes are down by 40%, whereas the acuity and the level of work is up significantly. And so it doesn't feel like volumes are down when you're changing PPE 100 times a day and coding patients with COVID and keeping your patients in the ED for hours longer. But overall volumes are down, revenues are down, and across the country, emergency staff have been cut. And so that's a challenge for me. I am not able to guarantee my staff their jobs. What I am able to say, and that I thank my institution for giving me this message, is that we are committed to keeping our frontline staff, our clinical staff, employed. That is a commitment of the organization. And so when belt tightening does occur, that is the last place they're going to look for belt tightening. And so it does make me wonder whether there are going to be shift reduction or cuts in certain benefits, things like that. And that's obviously one of the things that stresses our workers out the most. And it's pretty hard to message. They're all smart, savvy people, and they see the horizon. I see it myself. We haven't budgeted for the upcoming year yet. We're in the process of doing that, but I would say it's a source of significant anxiety. It's kind of ironic to be held up as a hero throughout the nation, but then feel like your job might be on the line. And so I guess the recommendation would be if you can talk to senior leadership and see if there's a commitment to preserve clinical staff's FTEs and to preserve benefits and pay for frontline clinical staff. I think that's a noble mission. It might not always be possible with the margins that hospitals are looking at, but obviously they're juggling a lot right now. I think it makes sense to advocate for the clinical staff who are putting in the sweat equity right now. Any questions? That was sort of the administrator experience of this epidemic. And then I'm going to get into actual clinical care, butt in the chair, sitting in the ED, how it feels.
There aren't any questions in the chat right now, but I'll put a message in the chat letting people know how to unmute themselves and that they can ask questions within the chat, and we'll read them out.
Perfect. Thank you. So now let's talk about actually being a frontline provider. So I kind of talked about coming into and leaving work. And one thing is funny, the entire building is flooded with food. So the community has been incredibly supportive, and we just have daily pizza deliveries and just there's a lot of sort of boxed lunch opportunities there, which is actually, I think, has actually been nice. It's hard to get to the supermarket, especially if you're a healthcare worker pulling 12s. You have to wait in line at the supermarket. It's, just one more thing. And so that's a place where the community has supported us that we really feel supported, and we're grateful for that. And it's been kind of nice not to have to bring a lunch to work and be able to eat your food out of the clinical area. You do need breaks from the clinical area. Regular surgical masks are okay, but the N95s are hot and sweaty. To get a good seal, you really need tight elastic fit. I think you've probably read articles about the skin on our nose breaking down. I definitely put tape over my nose when I'm at work to prevent, there's that metal band over the nose clip on the N95 that just sort of pushes those fibers. They're kind of the gritty fibers into the bridge of your nose. So I put a piece of tape over my nose when I'm at work to try to prevent from that. Fogging is the norm. They say things aren't supposed to fog up. I mean, I don't know what to say about that. Everything fogs up, even if you have a perfect fit. So anyone with glasses is kind of foggy the whole day. Your face mask is just dripping. I do my N95 fit testing. I can't smell the noxious chemical that means I have a good fit. But it seems like everything misses up throughout the day. So you're doing a lot of kind of cleaning your mask throughout the day and windshield wipering your mask. Obviously, we're in gowns and gloves. We are still wearing, in the respiratory ED, single gowns throughout the shift. In the regular emergency department, we now have a new category of patients where they are low risk for infection, but we're still ruling them out. For example, a long-term care facility patient who's asymptomatic. They would go to the regular emergency department, the non-respiratory side, but we would have them on COVID precautions until they tested negative with our rapid 45-minute test. And for them, we are using reusable gowns. So we now have some reusable gowns for the ED side, and we're sort of walking that line of keeping our PPE adequate while also testing people on the non-COVID side of the ED. And then I think we're all just very tired. It's just very tiring. There's something physically draining about it. I think about the N95, just the CO2 building up. I think I get a little CO2 narcosis after a couple of hours. You just need to take that thing off and stand in the ambulance bay and breathe some fresh air. I know people aren't sleeping quite as well. That's a common theme throughout the department, whether it's because they're underfoot and they're waking us up at 6 a.m. when the sun comes up, or whether it's just general stress of extra shifts and human suffering. But people aren't sleeping quite as well. And the response that we've had to that is to, one, we've tried to customize people's schedules as much as possible. So if somebody's really struggling, look at their schedule pretty intensely and say, how can I help you? Are you and your spouse trying to juggle shifts right now? Can I stack your shifts differently? Is it the nights? Are the nights killing you? Can we give you a pause from nights? Try to give some real attention to the people who are feeling it the most. We do have trained peer supporters. A peer supporter, there's about 8 of us in the ED, and we went through an 8-hour class on how to provide peer support. And it's really empathy training. It's how to listen to someone. It's how to put someone in their shoes. It's knowing which HR resources to point them to. And I would say our peer supporters were seldom used before this, and they are used more frequently now. And so I've been touching base with our peer supporters and asking them to reach out and sort of activate that skill set if they get the opportunity. And then, again, the organization has made this commitment to keep clinical staff employed. And one of the ways they've done that with the psychologists that we have in the community is that they've actually given us free counseling. And so we have a gifted social worker psychologist who is essentially there for healthcare staff exclusively, and they're free visits, unlimited, via Zoom meeting, and you can set up as many as you want. So I call it yoga for your soul. I've been doing my weekly counseling visit. And I think it's been helpful. It's just a chance to vent a little bit. And I know as a director, you don't have the same cohort of peers who have your same experience. I have my statewide network of ED directors that we talk via email, but it's not like we're on conference calls that much. And so this is an opportunity to sort of, for myself, sort of vent some of the maybe administrative headaches that I've been having. And so we encourage our staff to use it. I don't know who's using it. Don't know how frequently they're using it, but we just kind of shout it from the rooftops that extra support is there if they need to. Now on shift, this is kind of interesting. I would say the degree of suffering and death that we see in the ED is actually quite different than the floor of the hospital and the ICU. We are in a mode where we're trying to get people up quickly. So we're trying to diagnose critical illness or stable illness and get them up to the ICU or the floor as soon as possible to minimize infectious risk, and then to get them definitive care. We found that procedures in the ED are very time consuming right now, and that we're not well staffed for the increase of procedures. I mentioned we have an airway team now that will come down to the ED and do airways for us. And so we've been trying to, like, if someone needs intubation and there's an hour to do it, we've been trying to get them up to the ICU so they can do the intubation, do the central line, do the arterial line, all in the same room, in the same setting with sort of a procedure team. And as a result of that, we're seeing people when they're still holding their own. They're still on a non-rebreather, holding their own. We obviously still have cardiac arrest in the ED. We still have intubations in the ED, but they are less frequent than you would expect. And so our workflow feels, I would say, not too off from where it was before COVID in terms of volume, just because we're 40% down on our volume, but we're seeing sicker patients. It feels a little bit like a wash. Obviously, people are sicker. It's kind of taking that emotional toll. But in terms of the actual work you're doing throughout the day, I'd say feels similar. The ICU is a very different story. They are overwhelmed. And so they're calling in extra providers. They're changing their staffing model. They're opening up extra units. I know at Mass General, I think their ICU census right now is 160, and at the Brigham, the partner hospital, is 140 in the ICU. I mean, just those could be numbers for the hospital kind of thing. And so again, in Western Massachusetts, we're not as hard hit as that, but the ICU director is definitely, definitely feeling signs of burnout within their staff. And even on the floor, they're seeing a much sicker cohort of patients than they're used to. Previously in our community hospital, if you were on a non-rebreather and still hypoxic, you would be in the ICU setting. And those patients are certainly on the floor right now. And so I think that's just taken a toll on our inpatient colleagues in a significant way. It's sort of ironic that we're protected from it in the ED. I think if we had the New York experience where they were still sort of overwhelmed with lines out the door, we would be feeling it in the same way. But because our volumes are down, we've dodged that bullet a little bit in terms of emotional stress. We do have some on-shift resources. So if we have these all the time, actually, but again, it's just something we're using more frequently. But if we have a hard death in the department, classically a pediatric death, or someone who just something that kind of hits home, or someone who looks just like a family member, we have what's called a Take 5 box, and it's a little box with just a stress reliever in it, like a little sandbag you can squeeze on. It's got a snack. It's got some inspirational poems or quotes that the peer support staff has written for these boxes. We'll sit around and just sort of write nice things for the anonymous person who's going to open this box someday. It's got some personal care stuff in it, some lotion and a lavender thing to smell. And we just tell people, just go out, get out of here, get out of the building, go to the lawn, take your box, and come back whenever you're ready. And so just this idea of an unsanctioned, unannounced self-care break whenever you need it. And we've been really trying to just be good about that and offer that to people. We find that people won't take it themselves. You do have to kind of nudge them out the door and say, nope, it's time to take 5. And I think personally, I've taken 5 a couple of times, and I think it's meaningful and real. And so it might be a token offering, but it lets people know that you're thinking about them. So I would say that's been the staff experience. Now we've done director and staff experience, and I'll let anyone chime in on the chat box if you want before we move on to the experience of a behavioral health patient in the ED.
We do have a couple questions in the chat. So the first one is about standard pressure injury prevention and how that guidance is removal of pressure for 15 minutes every 2 hours to prevent tissue damage. Is that realistic in this environment?
Sure, I would say, in the ED, we have these thin cots, and I don't think we do that normally. So I know there's the 4 Ps of inpatient rounding every 2 hours. It's potty, pressure ulcers, positioning, pain, and possessions. That's not part of our standard ED workflow and not built into our EHR documentation. And so I'm trying to think of the inpatient world, whether that's possible. I think I wouldn't, I'm kind of speaking from the cuff here. I haven't talked to my nursing directors necessarily about it, but I don't see why that wouldn't be possible. We are staffed. We have enough staff to deal with these patients. There's enough closing of elective procedures, endoscopy, all these other things that we actually have nurses. And we're motivated to keep people at work. And so while the nursing ratios are probably smaller, it might have been 1 to 5 patients, now it's 1 to 4. Please don't quote me on those numbers. I'm making those up. But the patients are higher maintenance, but we are staffed for them, and we have PPE to deal with it. So I would think that's still possible.
So we got a little bit more info on that question. So what about for mask pressure relief for the healthcare professionals in the same manner?
Oh, no, it's, I would say it's do what works for you. We don't have a standard approach. Some people use moleskin, some people use tape. We did get approval from our CMO to use commercial masks. So some people bought these N100 masks, which isn't normal. This is actually widely discouraged because infection control can't really test those in the same way and have control over them in the same way. But some of our staff felt so strongly that they wanted those that our CMO granted that request. But I think it's just what works for you. I think some people, it's probably based on the face of your shape of your face and the shape of your mask. And some people the masks fit quite well, and some people they don't. And it's more of a custom experience. If you Google online, there's definitely healthcare providers with pressure ulcers from these masks. It probably has to do too with the way that your hospital's recommending PPE. So because we're cohorting into the respiratory emergency department, you only have to wear the N95s constantly when you're in that one environment. So if you're on the regular ED side, you can have a surgical mask most of the time, and then put on your N95 when you go into the COVID rooms or the asymptomatic patients who are being tested for COVID. So on the regular ED side, it's actually a little less stressful. And then when you have your respiratory ED shift, you're going to be doing that all the time, but you might only have 1 or 2 of those shifts per week. And so it's not like every single shift you're wearing the N95 24/7 or for 8 hours or 12 hours. And then I also read, are you using staff from other departments to assist with proning? In the ED, we haven't been doing full-on proning. We've been doing lay on your side. So we'll tell the patients to lay on your left side, lay on your right side, which evidence-based is a near equivalent to proning, and it's just a lot less labor-intensive. Most of the COVID patients that we're keeping in the ED for a while for a trial of therapy are fit enough that they can move themselves. And then I would say in the ICU, they have higher staffing needs to do things like proning, and there are quite a few prone patients up there. So I think that's a theme in this, is the individual patient requires more staff time than prior to COVID. Good questions. All right. So I know we are ending at half an hour, and I know we went long last time. How about I dive into the behavioral health patient? I'll wrap it up within about 10 minutes, and then we can kind of assess where we're at. Does that sound good?
Yeah.
All right. So I'll share with you our experience. We have a behavioral health pod. It's a 4-bed pod, and it's completely compliant, right? It's got all the safety and monitoring and everything that you need to be a safe behavioral health space. And then the patients spill over into the hallway. And we routinely board 8 to 10 patients in the hallways with behavioral health emergencies. It is not a good situation. It's not a sustainable situation. I would say it's the norm in emergency departments in Massachusetts. We are a very high boarding state. And so that was really the concern, was what are we going to do about this? The behavioral health population is often homeless. They often live in group settings like respite homes, and they often have just sort of chaotic family environments in general. I think we all know that we've all kind of learned that social distancing is a privilege of the wealthy. Not everyone has the same resources, and you can't social distance when you've got 8 people in a 1-bed apartment, right? And so this is a crowd that is prone to poverty. They're prone to low resources. They're prone to group settings, and they're really ripe for an epidemic of COVID. And it's the kind of thing that could devastate a community. So we were concerned about our behavioral health population very early on. And this is one of these, it literally brings a tear to my eye when I think about what our community has done for this. So first of all, they shut down the high school. It was already shut down, but they turned the high school into a homeless shelter and just significantly increased our capacity for housing. This was important because we shut down society. So all these people who sat in Starbucks all day these houseless individuals who sat in Starbucks all day or walked around Home Depot all day were coming to the ED. And the chief complaint was sandwich, warm bed and sandwich. It was still below freezing and snow on the ground out then. And so you just can't do it. In a public health emergency, you cannot do these sort of social admits and risk infecting people. And so we were pretty hard-hearted about it, I'd say. We were turning people away and saying, this is not a behavioral health emergency or not acute health harm to self or others. You got to go. At the same time, the police are intentionally arresting fewer people. That is probably not widely advertised, but they're intentionally arresting fewer people because they don't want a jail outbreak. And they are releasing people from jail in a motivated fashion to try to prevent a jail outbreak, and we actually had a jail outbreak. I think it would have been worse if they hadn't taken these steps. And so you do have, I would say, a cohort of, we incarcerate mental health in this country, unfortunately, but you had a cohort of behavioral health patients who are probably more prone to extreme substance abuse or to violence than we usually have, people who are usually getting their mental health care in a jail institutional setting. And so just maybe a little bit more need on that end in terms of agitated delirium and people who were, in intimate partner violence and things like that. Now, the interesting thing is the depressed population, the suicidal population has been way down. And I actually have been talking with my behavioral health colleagues about this. And this is not science-based, this is word on the street, but a lot of them will rate their clients' mood at the beginning of each session. And they've been saying that their depressed clients are actually happier than usual. And the explanation I got was that they sort of always feel down and always feel like the world is falling apart. And the fact that everybody else feels that way is somewhat uplifting. And they feel a little bit of sense of community because of that, which is kind of interesting. So in terms of major depressive disorder spiraling out of control, you would think just naturally that it would go up during a pandemic. And that has not been our experience yet. I would say it's plateaued or gone down. It could also be that people are fearful of seeking healthcare. I think that's possible too. And then for our anxious population, anxiety is obviously off the roof. But again, people are scared of coming to the hospital because we are the center where COVID is. And so ironically, our behavioral health population our entire ED population has been down, but our behavioral health population has been down even more so. I don't think that would have been the case if the community hadn't responded so well in terms of providing housing for houseless individuals. And then the government actually the state took control of a couple local hotels and made them COVID positive hotels. So when a houseless person is positive for COVID, they actually go to the hotel and get a hotel room, and they have CNAs and nurses in the hotels to treat these people. Again, reminding you that 85% of COVID is mild illness. It's a cough or a cold or a scratchy throat. Not everyone is hypoxic requiring ventilators. So we have thus far avoided a serious epidemic in the behavioral health population, and we've actually been able to keep our behavioral health pod at or near capacity by basically relying on these outpatient resources, really trying to move people through the system. The state also passed an emergency law that no psychiatric facility could deny a patient because they're COVID positive. And so psychiatric facilities have to take these patients. This probably makes some people groan. I understand that if you don't have the capacity to take COVID positive patients and the state mandates it, that puts you in a very tricky situation. For long-term care facilities, I know Massachusetts is one of the few states that actually designated certain facilities, you are going to be a COVID positive facility, and they'll move people. So instead of 10 long-term care facilities having one positive patient each, they will say, facility X, you are now the COVID facility. The state will mandate that, and they'll move people. And so you'll have 9 with no COVID patients and 1 with 40 kind of thing. And so the cohorting at that level, I think, has also been, I don't know it's hard to say how effective it's been. We need more data from other states. Our long-term care population has been hit very hard. And I know that the New York Times just did an article that 1/3 of the deaths nationwide have been in long-term care facilities. And I think in Massachusetts, where about 60% of our deaths have been in long-term care facilities. So it's hard for me to say if it's working effectively. I suspect that it is. I think the scope of the problem would be worse if the state wasn't cohorting the way that it was. But as this epidemic kind of rips through the nation, maybe we'll have a better idea of what best practices are. It's really hard to ascertain right now. And then I know I'm running up on time here, but the other kind of shining point in terms of the behavioral health population has been our outpatient crisis services. So traditionally, our crisis services were very hospital-based. It was sort of like, they're a couple miles away. These are the mental health workers who will after a psychiatric patient has been medically cleared, which involves a bunch of testing, they'll come and decide whether they're appropriate for outpatient, respite, or inpatient care. And so I would say that our crisis organization prior to the epidemic was not as responsive as we would have liked. They would sort of batch patients and take a long time to get to the ED. They'd wait till there's 3 or 4 patients in the ED, then kind of come all at once. We had the impression, whether it's fair or not to say it, but we had the impression that the easy route was sort of to say inpatient for patients. And then we get this long backlog of patients requiring inpatient, and it would require 5, 6, 7 day stays in the ED, psychiatric boarding in the ED before we could find a bed. And it was, there was frustration on all sides with the behavioral health situation. They've gotten a lot better. I mean, and we've tried to adapt with them as well. What we're experiencing now is a strong desire to do the initial triage in an outpatient setting. And so when patients call our crisis services organization, they won't say go to the ED, they'll say come to our office. And they're doing a lot of the evaluations in the office and trying to bring only the agitated patients or the most acutely suicidal patients to the ED. If someone does present to the ED initially, we've approved a protocol. It's called the SMART protocol. It's out of Sacramento, where we can actually medically clear a certain cohort of patients without doing labs on them. And so these are young patients with normal vital signs, no comorbidities, known psychiatric illness, and no substance abuse. Those patients would risk stratify as low enough that they don't require the battery of labs that are sort of routinely sent. And that'll keep patients in the ED for a much shorter amount of time, so we can actually get them to the outpatient evaluation site. And our crisis service organization is actually paying for cab fare to bring them there. And then they also have teleservices. So if it's off hours and they have limited staff and they're in other sites, they actually have an iPad that they carry with them, so they can do an iPad evaluation in our ED. And then on the inpatient side, our psychiatrists have initiated 24-hour consults on all patients with a specific goal of seeing if there's an alternate disposition for inpatient bed search. So, sometimes you get people back on their meds or you get them out of their chaotic environment and they're better. They say, no, my mood's stabilized. I think I'm going to keep taking my beds. I can go home. But it's sort of tough for an emergency physician to reverse the course that was already set by a mental health crisis worker. And so we ask our psychiatric colleagues to weigh in on that, and they've been great about that as well. And so I would say the experience for our behavioral health population, I would like to think has been good. We're trying to keep people out of the ED, which is not the most comfortable place to be if you're in a psychiatrically stressful situation. We are trying to keep people in their homes, and we're really trying to meet people where they're at with medication adjustments and accurate diagnoses and outpatient resources. And so far, there's, the stress on the system hasn't been enough to break it, because overall visits seem to be down, across the board. And I just saw a bunch of questions pop up, so I think I'm going to pause naturally there and address some of those.
I think we just had some resources shared.
Oh, perfect.
Some Superior Health resources that were created about COVID-19 infection prevention and safety at home. That Michigan does have some regional hubs as well, and things like that. I did get a private message. So what's the SMART protocol? Do you guys use that?
Yeah, that was that. There's multiple protocols for medical clearance of psychiatric patients without excessive labs. The nationwide standard, which is universally agreed upon as bad, is to basically send all the labs on psychiatric patients to rule out medical illness. So CBC, CMP, tox screen, urine drug screen, all these things on basically, oftentimes these are healthy young people who are feeling depressed. And it just, EKG, all these things. And as emergency providers, we kind of roll our eyes at a broken system a lot. And so there's been a lot of movement to try to have standardized protocols to shorten that. And they're hard to get implemented because it's dogma. We've done it this way for so long. And so you can Google, it's SMART, SMART protocol for expedited medical clearance. It came out of Sacramento. It's validated in the literature. And I would say this is not a common thing. This is something that pre-COVID, we probably wouldn't have been able to operationalize, because you can always say, oh, well, what if this patient's DKA and we miss their illness, or, something like that. And you can always sort of have that spectrum of risk to say why this is an unsafe way to do things. And it's one of these things that goes on because of inertia. So I would say because of the situation we're in, where we really can't be goofing around, keeping people in this, during this epidemic, an environment where they could get infected, we said, no, we really have to move towards this. The risk of infection outweighs the minute risk of missing a medical illness here. And our inpatient and outpatient colleagues were receptive to that. So we'll see if it persists after the epidemic. That's actually something that I'm interested in. Now we're going to have some data. We'll see how well it works in our setting. Because of this crisis, we have sort of a natural experiment. And so we're going to analyze the data and see if we missed medical illness, see if we were screening people appropriately. And I would like to see that as a legacy from this, that we continue that practice. I think it's best for our behavioral health patients, but I'm one of many, so we'll have the discussion and see how it goes. And there's many other options besides the SMART protocol. There's no commercial relation, anything like that. These are freely available assessment tools, and there's multiple different flavors of them. Oh, I see someone posted the link. Perfect.
Elena, any more questions in chat?
Not that I'm seeing right now.
Okay. Just a reminder to unmute your phones. If you're on a regular phone, you may need to push *6 in addition to your unmute button. If anybody has any questions, feel free to chime in.
Dr. Redwood, this is Eva from Superior Health. I wanted to see if you could maybe touch on anything that you at your organization are doing to help address health disparities within the COVID pandemic, such a critical topic.
Yeah, absolutely. I would say our hospital in general is very progressive in terms of addressing economic disparities, racial disparities, and gender identity disparities. And so at baseline, I think our hospital is really in tune with this, and we have specific admin personnel with that as their full-time job, is to address disparities in the healthcare setting and sort of make sure that people are getting equal care. That being said, I think what you're probably getting at is that COVID disproportionately kills poor and brown people. And that is largely a result, I think, of longstanding structures in society, not just medical discrimination, but housing discrimination and food security and all these other, real issues that America has been grappling with for years that are being brought to the forefront by this era of scarcity. And I would say most of the innovations that have been rolled out to address this have been at the community level. And I don't have a long list of those. What I can tell you is our care manager routinely publishes every week sort of a list of community resources that are available. And I mean, it is vast. So we have, substance abuse counselors where you used to have to go to them and they'll now come to you. We have STI testing and HIV testing resources where you used to have to go to them and they had limited hours, and now they're doing home calls. I mentioned the homeless shelters and the hotels and sort of living situations. The food banks have been incredible. So it seems like every church in town has tables out front with boxed lunches where people can come get food if they need to. And then testing is we are doing testing for symptomatic people who don't have insurance and eating the cost on that. I probably, again, shouldn't advertise that widely, but we're basically, we as a health system are just eating the cost on that and testing the uninsured or people who are out of network and things like that, and not really, trying to think of this as more a public health and greater good mission than a bottom line type of thing. I would say that is the state of affairs. I think this is so much bigger than a hospital, that we as a hospital try to keep up our usual best practices, but we're largely relying on the community, and I think our community's done a really good job, honestly. So it's such a broad question. I hope I answered it correctly. If there's more nuance to it, or you want to dive in on something specific, please let me know.
No, I think it's very helpful, and I appreciate you sharing. I bring up the topic because I know that, states have done tremendous work to kind of help address it. And I think from the public health as well as health and hospital perspective, I think the job that you just alluded to making sure that we're communicating with our patients and the residents to kind of share these resources publicly and widely is critical. I know a lot of rural hospitals have developed weekly community calls where they welcome the community to publicize it publicly to help address these type of concerns and help spread, good information. And I think that, healthcare seems to be like a trusted source for people to go to sometimes. So I think it's just critical to get these resources out. Thank you for touching on that.
Of course. The population I do worry about is this uninsured and underinsured population, right? Like if you get critical, we're going to treat you. You come to the ED and you need intubation, you're going to get treated. But what if you're not? What if you're just, what if you're kind of smoldering at home? We have people who come to the ED and we triage them. They're COVID positive. They have maybe a mild oxygen requirement, but not severe. And the O2 drop tends to be at about day 10. So we call them the happy hypoxics. They'll be cruising along with these low O2 sats, but they're doing pretty good. They can eat and drink and toilet and interact. And then around day 10 is when they prove whether they're going to crash or not. And so we have visiting nursing associates, home healthcare workers, who will go to people's home and test their O2 sats and bring them oxygen if they need to. But that is a resource that is largely available for the insured population and those seeking healthcare. And I would say that's something that keeps me up at night, is that cohort of patients that, they're already strapped for cash, they can't pay the rent, and they're not seeking care that they probably want to seek because they're underinsured or uninsured. And again, we're a little bit luckier in Massachusetts because we do have, like the Obamacare was based on Massachusetts care, and so we do have a public option here, and our number of uninsured patients is quite low. But I think that states with great economic disparities and great underinsured populations are probably going to experience more morbidity and mortality in their because of disparities, whether it be the economic disparities or racial disparities, et cetera. And then we have a very language diverse population. And it's been our language line, though, because our population is so language diverse, we also have a ton of translators, which has been nice. And so we have the rollable iPads to provide appropriate language care for people. And then the Harvard and the Boston hospitals have basically translated all the COVID resources into every language. I don't know if they did it themselves or found it elsewhere, but that's sort of available in Epic. So most languages you can find appropriate language resources on COVID.
Thank you. It looks like we just had a couple other resources put in the chat pertaining to both of those things right there. So if you're looking for more information, definitely check those out. Thanks, Eva. I don't see any other questions in the chat. Just as a reminder, if you are joining us by phone, you can press *6 to unmute yourself if you have any questions, or add them into the chat.
I'll say one thing. I was reading through my notes here on behavioral health population. There's one I skipped. The heroin overdoses have vanished, and we have no idea what's happening. We suspect that people are overdosing at home and not seeking emergency care because of fear of coming to hospital. And it could also be a supply chain issue that heroin's not getting there. I know ordering anything online takes weeks, and a lot of the fentanyl comes in through the mail these days, unfortunately. And so maybe there's actually interruptions to the supply chain for opioids. But it's just kind of weird, and we are not seeing opioid overdoses. EMS isn't seeing them. It's been like a plateau drop off, and I don't know if other health systems are experiencing that. Our response has been our local substance abuse, like community substance abuse hubs. We have asked them to message their patients that, hey, the ED's open, we're here, we're safe, don't overdose at home, be sure to keep your naloxone prescription filled, these kind of things. But it's just sort of a weird quirk of this epidemic, and I honestly don't know what's happening right now.
Well, thank you, Dr. Redwood. Do we have any additional questions?
Don't see anything in the chat right now.
I have a question. This is Jessica from Michigan. I was just curious if you're seeing any of those new pediatric cases that we've heard about on the news.
Oh, funny you should ask. Our incident command team addressed that this morning. I know New York has about 100 cases. This is an inflammatory syndrome that affects the arteries, like a reactive vasculitis. If you've ever heard of Kawasaki disease, it's similar to Kawasaki, but it seems specific to COVID. And New York's had about 100 cases. And I would say that, and they tend to happen 3 weeks out after COVID, and they're not always identified because the kids get such mild disease that they might not even have been tested or had severe symptoms. And so we have not seen a lot in our hospital. No, we're also not a pediatric center. In fact, we have such a robust pediatric center right down the highway from us that a lot of pediatric cases just bypass us and never hit our doorstep. And so that being said, we are on alert for it. I actually have a webinar on that. No, I'm not giving it. I'm listening to a webinar on that later today. And that's sort of a hot topic this week that we're just starting to see come out into the hospital population. And so, I think next week even there'll probably be a lot more information on it. Right now, it's about case collecting and trying to define the spectrum of disease, but it's a real thing. I know the Department of Public Health in our state just added, they keep expanding on their symptom list for COVID. So they just added nausea, vomiting, altered mental status or CNS deviations, and COVID toes, where your toes turn black and blue, sort of like chilblains. And so we've been seeing these in the ED for weeks, but they just added them to the official list of symptoms, which is relevant because it affects who get tested. So last week we didn't have COVID toes on the list if you came to get tested, and that was your only symptom. You wouldn't have received a test. Now you will.
No, we do have a comment in the chat just that they've noticed quite a few members losing their lives, it looks like to overdose, and they're not sure why the reporting doesn't reflect that. I believe that's what that comment is.
Yeah. I mean, the New York experience has been tragic. They're just finding people dead in their homes. Not just from opioids, but from COVID or whatever, heart attacks. I think people are afraid to seek healthcare. And so that's been part of the EMS experience is, you go for a welfare check and you find a body. And obviously this is the AODA population can sometimes be a hidden population or a silent population. And that doesn't surprise me that it's happening and that it's not being reported yet.
Is there anything
not to end on a downer? Mm-hmm.
Kind of along with that, though, is there anything that we could do as healthcare professionals to let people know that it's safe to still be seen in the emergency room if you're having an emergency, so that doesn't happen to so many people?
Yeah, absolutely. It's a tough line to walk. We're giving society a mixed message. We're telling them only come if you need to, stay home. We don't want to overwhelm our healthcare system, which is accurate. And then we're telling them, hey, the ED is still safe if you're having an emergency. And what we've done is try to use telehealth and triage through the primary care line. And so you can actually, the primary care physician can look at the patient, determine if they look sick, and then say, no, you got to go to the ED, and sort of use that as a gateway and really try to keep that available. And so they're doing more frequent visits. They have a lot of availability because everybody's at home anyways, and kind of worried about not making any money, with not being able to be in clinic and stuff. And so at least in our area, we have a wide availability for primary care telehealth visits. And that's been a middle ground, because traditionally when you call the triage line, I don't know what your experience is in, but the triage line always says go to the ED. That's been my experiences. You call triage line and they say, oh, chest pain, shortness of breath, anything. You should probably go to the ED. Maybe I shouldn't villainize the triage line, but it seems like a pretty low threshold for going to the ED. And that's changed a bit. It's honestly changed a little bit because while there's while I would say it's safe to seek emergency care, there is a risk. I would say there's an infection control risk that's real. And so that's been our solution. We do message widely that the ED is safe. We widely message that we have cohorted patients and have a dedicated respiratory ED. We're particularly messaging about stroke because there is an increased incidence of ischemic stroke during this time of COVID. And then AODA and substance abuse. So we're trying to message it out that things are open for business and please come in if you have emergency symptoms. And then we're using the primary care portal, telehealth portal, to try to do some of that triage a little more accurately. I don't think there's a perfect formula. I think it depends on what structures you have built and how you can use them creatively to walk that very real line between infection control and seeking emergency care when you need it. But I would err on the side of seeking emergency care would be, obviously be my recommendation. So.
Thank you.
Mm-hmm.
Okay, we have about 5 minutes left. Do we have any additional questions for Dr. Redwood?
I don't see any in the chat right now. I do just want to give everyone kind of an update. Next week call will feature someone from the Midwest Kidney Network. So please feel free to join us next week for that.
Okay. Well, I think
thank you everyone for the opportunity to present today. It's really been a pleasure. And I wish you luck. Like I said at the beginning, we're all in this together, and thank you for supporting. I know we have a lot of quality improvement professionals on the call, and just thank you for supporting the frontline staff and providing the data that we need to fight this epidemic. It's just really meaningful work now more than ever.